Well, my dog says hello too, and apologies for that. Solstice, come. This is Liz Woodruff. I'm the director of the Idaho Academy of Family Physicians. One second. I have to put a little bit of my lunch on my finger so that she'll quit barking. I'm happy to welcome you all today for the IAFP's May Grand Rounds at a special time, since we are grateful to have the Kootenai Health Program and Dr. Micayla Lessard here to talk about PCOS and long-term health considerations. In the chat, you will find information about how to receive a CME for this event. You can either fill out the short Google form or email me. The Google form system has changed, and we have had some problems with these links over the last couple months. So if you have an issue, don't hesitate to just email me and let me know you were here, and we'll make sure that you receive CME. Dr. Lessard will give her presentation, and you can write your questions into the chat. During her presentation, she will answer those at the end. We're hoping to last about 45 minutes. And then if you have questions at the end, you can also unmute to ask those questions. I will be dropping the CME information in the chat throughout the presentation, so hopefully that's not too distracting. CME certificates will be sent out within the next month for those of you who fill out the form or email me. And the recording of this will be on the publications page of the IAFP website, though not for credit. So with that, I'm going to hand it over to Dr. Lessard. Please go ahead.
Awesome, thank you. As Liz mentioned, my name is Micayla Lessard. I'm one of the graduating or soon to be graduating third years up in Coeur d'Alene at the Kootenai Family Medicine Residency. Today, I'm chatting a little bit about PCOS and particularly the long-term health considerations that I think are often overlooked and things that are very much well within the scope of what the primary care office can provide, even if you are not someone who generally does a lot of women's health. All right, come on, computer. There we go. I have no financial disclosures. From a learning objective standpoint, I really just want to make sure that we're acknowledging what a complex condition PCOS is and that there are several significant long-term health considerations. We'll review the proposed pathophysiology, review diagnostic criteria, talk about the labs that are part of the assessment and workup, talk about additional testing and monitoring, particularly pertaining to those long-term health considerations, and then review standard treatment options, particularly those that are, more than appropriate for us to be doing in the primary care office. And then if there's one thing that you take away from my talk today, just an emphasis that PCOS is not just a disease of obesity. It's not just caused by obesity, and we are really doing our patients a disservice if that's the way we're thinking about it. Unfortunately, there's not really a great all-encompassing definition of what PCOS even is. So the best that you can kind of put together is it's an endocrinopathy that results in an imbalance of reproductive hormones in patients with ovaries, and it most commonly presents with menstrual cycle irregularity and symptoms of hyperandrogenism. There's not actually an agreed upon prevalence. Some sources will say 3, some say as high as 18. Generally accepted is about 10% of the reproductive age population. For comparison, type 1 diabetes is less than 1%, and hypothyroidism is less than 5% of the reproductive females in the US. So this would be, by and large, the most common endocrine condition in reproductive age women. It's a very heterogeneous presentation, and then there's a lot of reproductive, cardiovascular, psychological, metabolic, and cancer risks that these patients are at increased risk for, and unfortunately, a lot of that is overlooked or just not well understood by primarily the primary care office. We should probably care a little bit more about our deficiencies in understanding PCOS because patients are really suffering for that. There was a pretty comprehensive study that came out of Pennsylvania. A third of patients had to go 2 years while their doctors were trying to figure out what their diagnosis was. About a third needed to see more than 3 providers. About 12% saw 5 or more just to get a diagnosis. And of course, seeing more providers, those folks that saw 3 or more, had a pretty significant negative association with the whole process. When you look at the things that kind of matter to patients, only about 35% felt like they were satisfied with the diagnosis in the end. Excuse me. 15% satisfied with the information they got about the condition, and less than 10% were satisfied that they received really any good information about long-term health complications. Bear with me as I'm getting over a cold. There is no agreed upon pathophysiology for PCOS. But there are 2 proposed theories. The first theory is that starting at the level of the hypothalamus, the signals that are being relayed from one of my colleagues had a similar issue when she was giving her grand rounds and felt so bad for her. She looked so miserable, but don't worry, I'll get it together. One of the proposed pathophysiology pathways for PCOS starts at the level of the hypothalamus, and it's this idea that there is an increase in the pulsatile release of GnRH from the hypothalamus acting on the anterior pituitary, which results in increase in LH and FSH production. If we're following sort of the left side of this pathway through with LH, we're ending up at the level of the ovary, and we're seeing increased level of androgen production. FSH then acting on follicle maturation and development. Unfortunately, as we see increasing level of androgen production, we see increasing level of estrogen, and these cycle back to actually decrease the amount of FSH that's being produced and increasing the amount of LH that's produced. So as you have increased pulsatility, increased secretion of both of these hormones, you end up with downregulation of the right side of the pathway and funneling down to androgen production. The second theory about what's potentially happening causing increased androgen production in PCOS patients is that there's something else going on in the body, not in the brain, that's resulting in increased steroid production. So whether that be a dysregulated primary production of steroids at the level of the adrenal gland itself, or at the level of the ovary itself, some variety of genetic mutation. The other thought there is that as adiposity increases, or as people's weight increases, we know that there's increasing insulin resistance and increasing insulin production. And insulin itself has the effect of increasing androgen production at the level of the adrenal gland. They've seen this when they've studied incidentalomas and things like that. So these are the 2 thoughts about what maybe is happening, that there's some predisposing event that's causing increasing GnRH production, or there's something going on systemically that's resulting in increased steroid production. So how do we make the diagnosis? A lot of us will have heard of the Rotterdam criteria from medical school, but there's actually 3 criteria that have been proposed over time that have looked at different or worded things slightly different. So the NIH criteria came out in the 90s, and they said you need to have hyperandrogenism and chronic anovulation, specifically those 2 things. Rotterdam came out in the early 2000s, and they said, again, hyperandrogenism, but we're going to widen our definition to say anovulation or oligoanovulation. And then let's add this component of a polycystic ovarian morphology. Let's look at what the ovaries actually look like. The Androgen Excess PCOS Society came about a couple years later and said, well, let's keep with hyperandrogenism, and then let's just be real vague and say ovarian dysfunction and go with those 2. There's been a couple of studies that have come out. One came out of Italy that looked at women with suspected PCOS and went off of each 3 diagnostic criteria. And with the NIH, about 51% met the criteria for PCOS, Rotterdam about 83%, and then the Androgen Excess Society was looking at about 70%. Similarly, there was a study at a fairly large institution. It's a referral center for ovulation issues. And they looked at these women and tried to diagnose them based on the Rotterdam and the NIH criteria. And what they found is that about 91% of women were meeting diagnostic criteria using Rotterdam versus 55% with the NIH. So the thought here, and what probably why there's such a big difference in prevalence or proposed prevalence rates, is because different people have used different diagnostic criteria over time. And it's only in the last handful of years that there has been guidance that the Rotterdam criteria really are probably as close to the gold standard as we're going to get, or at least they're the most realistic criteria that we should be using. When the international guidelines on PCOS in 2018 came out, they did offer a couple points as reminders, and that is that if you meet the other two criteria, you do not have to do an ultrasound. We do not need to do pelvic ultrasounds on all of these patients. And then also, if it's an adolescent patient and they're within 2 years of menarche, you should not be doing an ultrasound. There is not accepted criteria of what their ovaries should look like on ultrasound, and we'll circle back and talk about that a little bit more. So as a reminder, Rotterdam criteria, you're looking at irregular cycles or ovulatory dysfunction, clinical or biochemical hyperandrogenism, and polycystic ovarian morphology on ultrasound or an equivalent lab test. So let's walk through these individually and give maybe some more specific information. If the first note for cycle irregularity is that if this is the first year post-menarche, irregularity is expected, and that's not necessarily a reason to be working people up. However, another point is if you have primary amenorrhea, no period by age 15 or 3 years after breast development, that is suspicious for some variety of reproductive pathology, and you need to be assessing these patients regardless if they have concerns for PCOS or not. There's something else going on. When you are specifically referring to menstrual cycle irregularity with PCOS, they break down the criteria based on time from menarche. So if you are at least a year from menarche, if you have any one cycle, or if you have cycles that are lasting more than 90 days without another good explanation, that meets your criteria. If you are 1 to 3 years post-menarche, you're looking for cycle days that are cycle lengths that are less than 21 versus greater than 45 days, or cycles lasting, again, more than 90. And then once you're at the 3 years to the perimenopausal point, cycles less than 21 days, cycles greater than 35, less than 8 cycles per year, or again, cycles that are greater than 90 days in length would all get you the criteria of ovulatory dysfunction. Hyperandrogenism is basically the physiologic or biochemical evidence of elevated free testosterone. If we're starting talking about how you would measure this biochemically, that is by measuring free testosterone. A couple of notes there is if as a patient is on a combined hormonal contraceptive pill, they are going to need to be off of that for upwards of 3 months before you can feel like you get an accurate test result. Mostly because estrogen increases the sex hormone binding globulin, which is what binds up free testosterone. So that's going to be really important. We're going to come back to that several times throughout this presentation. When you measure testosterone, you should be doing free and total. Free is going to help you establish your diagnosis of PCOS. That is the metabolically active version of testosterone. There is a fantastic document from the American Society for Reproductive Medicine that walks you through the diagnosis and management of PCOS. And they specifically say just use your lab's reference ranges, that there's not actually a agreed upon hard cutoff of what is elevated free testosterone. Total testosterone is not necessarily utilized to make the diagnosis of PCOS, but it is needed to rule out a hormone-producing tumor. So if you have a total testosterone that's significantly elevated, that's concern for a testosterone-producing tumor, and you need to work that up as well. If you are talking about clinical hyperandrogenism, that usually is seen as hirsutism, which is the growth of coarse, terminal hair in a standard male pattern, but on someone who is trying to present phenotypically female. And that is incredibly sensitive for hyperandrogenism. It's not particularly specific to PCOS, but it is sensitive for hyperandrogenism. There is a tool that can help you be more objective in your diagnosis of hirsutism instead of just saying, oh yeah, that looks like atypical hair growth. And we'll look at one of those scales together. If a person has female or male pattern baldness, if they've got really significant, what looks like hormonal acne as an adult, it's a weaker predictor, but it could still get you that criteria of clinical hyperandrogenism. So if we were to look at these two patients, even though this patient has dark coarse hair on their head, if they were trying to present phenotypically female, we would all agree that you wouldn't expect to see dark hair growth along the jaw, on the side of the neck like this, maybe on the back of the neck, depending on where their hairline is, but this would be considered atypical. And looking at this patient here as well, you can see kind of increased hair on the upper lip, coarse, dark, curly hair on the chin. Again, if presenting phenotypically female, wouldn't necessarily expect that kind of hair distribution. A modified Ferryman-Galway scale can be used to objectively help you achieve a diagnosis of hirsutism. It's looking at 9 body zones, and the pictures actually help walk you through the density or prominence of hair growth. And scores as low as 4 to 6 actually warrant investigation, and that will be dependent on the population that you're working with. So if you have like Asian patients compared to, say, an African American patient, an Asian patient will have a much lower score that it's recommended that they be assessed at. Something that's important to remember, and it's actually in the top of the scale as you're going through it, is that if you have patients who are going through cosmetic hair removal or any variety of hair removal, which a lot of them probably are, remembering that that's going to falsely lower your score. So we've talked about irregular menstrual cycles. We've talked about how to objectively diagnose hyperandrogenism. The other thing that you can look at is polycystic ovarian morphology, primarily on a transvaginal ultrasound. That is going to be most accurate. If you are doing transvaginal, your criteria are going to be 20 or more follicles per ovary in any one of the ovaries, or any one ovary with a volume of 10 mils or greater. Or if they do a cross section, so what this image is showing is just a cross section through an ovary and you see 10 or more follicles per section. If you have to do transabdominal, it's not preferred, but it is an option. Probably don't try to assess the follicles per ovary because it's really hard to get a full ovary assessment in transabdominal views. And then there is no definitive criteria for what polycystic ovarian morphology looks like in adolescence. In those first couple of years of maturation of kind of the hormonal axis, they are going to have increased number of follicles. And the problem is we just don't know enough to say when is that actually pathologic. So this is to the comment about why you should not necessarily be doing ultrasounds in patients that you're trying to diagnose with PCOS if it's within 2 years of menarche. If an ultrasound is not an option or you're doing lab tests anyways, you could try doing anti-Müllerian hormone. So this is a hormone that's produced by the antral follicles in the ovary and helps with folliculogenesis. It's elevated in PCOS, likely because they have multiple follicles maturing at once or trying to mature at once, but also that they think the follicles produce more of the hormone at any given time. I found this interesting, the thought about why do we have anovulation with PCOS, and it's that the increased level of anti-Müllerian hormone causes the follicles to mature faster than the egg within them. And this dissynchronousness is what results potentially in the anovulation in PCOS. So different groups, they've been trying to come up with a definitive cutoff that says if AMH is this high, then there's probably more follicles maturing at once than is appropriate. Unfortunately, there's not a definitive cutoff, but even the American Society for Reproductive Medicine will say if you're somewhere north of 3.8, but definitely if you're north of 5, that's probably sufficient to get you the polycystic ovarian morphology criteria. Similar to testosterone, though, if a patient is on a combined hormonal contraceptive, it's going to falsely lower AMH levels. So this might be something, if you're going to have someone be off their OCPs for 3 months and you're going to check a testosterone level, it's probably not unreasonable to do this as well. While you're getting those lab tests, a few other things you should rule out, right? Someone with a no period, make sure they're not pregnant. Make sure that you're not dealing with significant thyroid dysfunction or prolactinoma. 17-OHP looks at non-classical adrenal hyperplasia. The classical is going to present at birth or nearly thereafter, whereas the non-classical usually is around pubertal time. It's usually in people who are like genetically female and can be a little bit more mild in presentation. Depending on how old they are, FSH, LH, and estradiol can help determine if they're just in the perimenopausal or like early premature ovarian failure. As with any patient with significant abnormal uterine bleeding, you should be making sure whether or not an endometrial biopsy is appropriate and should be considering that, even if you're also working at PCOS. And this actually is important that we will circle back to. And then a final note as you're thinking about your workup is if symptoms are rapid onset, high severity, they're really rapidly progressing, patients have clitoromegaly, voice deepening, that is an androgen producing tumor until proven otherwise. Until you can prove that they do not have some variety of tumor, if their symptoms are that intense or progressing that quickly, that is your primary goal, is ruling that out. Fabulous, great. You have made a diagnosis of PCOS, which I feel like is where all of us get to in med school, and that's about it. So now what do you do for these patients? Additional investigation that you should be doing. So PCOS patients are at a significant increased risk for depression, anxiety, compared to BMI match controls, also at increased risk of eating disorders. I think probably in the primary care office, we're all pretty good about doing PHQs and GAD-7s on our patients, but these definitely need to be done in this patient population. They have a significant increased risk for sleep apnea compared to women or patients without PCOS, and that's compared to a premenopausal control group. So these numbers, I think, come a little bit closer together in your menopausal group, and they don't necessarily account for BMI in this particular study. Again, considering your endometrial biopsy as appropriate if there's significant abnormal uterine bleeding, treat them like you would any other patient. But this is where I'd like to spend a little bit more time looking at cardiometabolic risk assessment for patients. So this is something I think, again, we're very suited to assess and watch for in the primary care office, but really gets missed fairly often. Metabolic syndrome is a constellation of risk factors that we know are directly related to and promote the development of atherosclerotic disease. The diagnostic criteria, you need 3 of the 5, but it's an increased waist circumference, increased triglycerides, reduced HDL, elevated blood pressure, or an elevated fasting glucose. And what we know is that if you meet the criteria for metabolic syndrome, you have a 2-fold increase in your relative risk of going on to develop, of having an ASCVD event, and a 5-fold increase relative risk of developing diabetes. When you take that and apply it to patients with PCOS, PCOS patients are twice as likely as their age-matched controls to have metabolic syndrome. So in theory, twice as likely, or compounding the risk of developing diabetes or having a cardiac or a neuro event. And PCOS has been shown to be associated with increased incidence of both MI and stroke. So when these patients are coming into your office and they've been diagnosed with PCOS, or you're diagnosing them with PCOS, also assess them for metabolic syndrome. So measuring their waist circumference when they're diagnosed and doing that annually, especially if they have significant fluctuations in their weight. Doing cholesterol screening. This should be done at the time of diagnosis. There's not a specific recommendation from an endocrine standpoint about how often they should be screened thereafter, but I think it's reasonable to apply similar strategies that you would in a non-PCOS population. And there is data out there that shows that regardless of whether a patient with PCOS is obese or non-obese, they have less favorable cholesterol profiles. So they have higher total cholesterol and increased LDL. We should also be screening these patients for hypertension annually. We know that in the premenopausal PCOS patients, they are at increased risk of hypertension, but those numbers tend to even out once you hit the menopausal age ranges. So with metabolic syndrome, if we're monitoring this, we know that they are modifiable cardiovascular risk points. So making sure you're treating their hypertension, treating their high cholesterol, monitoring what their weight fluctuation is doing. Insulin resistance, which insulin resistance and hyperinsulinemia gets used very interchangeably in the literature about PCOS and are considered essentially equivalent. But we know that as insulin concentrations increase in the body, androgen production by cells of the ovary and the adrenal gland are increased. We talked about that earlier on. And it also reduces sex hormone binding globulin. So you have more androgens and less protein to bind it up and to make it metabolically inactive. So hyperinsulinemia is present in 75% of PCOS patients with a totally normal BMI. Now, if they have a BMI above 25, you're looking at 95% of the PCOS population. So virtually all of PCOS patients, if they have an elevated BMI, will have some degree of hyperinsulinemia or insulin resistance. When you look at their type 2 diabetes risk, you're talking about an almost threefold increased risk for developing type 2 diabetes in these patients, regardless of what their familial risk is, regardless of what their other risk factors are, just the presence of PCOS alone. As a result, all patients should be screened with a 2-hour glucose tolerance test at the time of diagnosis. A1C is okay, but not preferred. If that test is totally normal, if they have normal glucose tolerance, but they have other risk factors for diabetes, strong family history, they are obese, that sort of thing, then an A1C every 2 years is reasonable. If they have impaired glucose tolerance, then you should be doing an A1C annually for those patients. Cycle irregularity and endometrial cancer risk. The cycle irregularity is probably one of the most visible things to patients. But what we know from a cancer risk is that when you have reduced number of ovulation events, so you're having more frequent unopposed estrogen and less progesterone, then that increases your risk for dysplasia and endometrial cancer. Again, that almost threefold increased risk of endometrial cancer in PCOS patients compared to the control population. And what we found is that specifically intermenstrual interval of greater than 90 days is where you see that break off of the statistically significant increased risk of hyperplasia. If you are doing an ultrasound for some reason on a patient and you find that they have an endometrial thickness greater than 7 millimeters, that is also a tipping point where we have increased risk for hyperplasia and progression to endometrial cancer in PCOS patients. This is why, just like you would anybody else, if the bleeding profile is significantly abnormal or they are regularly having cycles lasting more than 90 days, so they're going more than 90 days without a period, these patients should have an endometrial biopsy as part of their PCOS workup. A lot of patients are also going to be coming to you or going to be very visible because of their fertility issues. Because of the anovulation and the irregular cycles, it takes an average of 2 years longer for these folks to get pregnant. Childbearing, or I should say the rates of live childbirth also goes down. So there's a higher miscarriage rate. Only about 55% of spontaneous conception will go on to a live birth for PCOS versus 73.8 in a non-PCOS population. If you're using reproductive technology, that number evens out. Patients with PCOS are basically at increased risk of every complication of pregnancy, weight gain, GDM, hypertension, preeclampsia, small babies, preterm babies. Regardless of your BMI, you are at a more than threefold increased risk of gestational diabetes, which unsurprising given the significant increase for type 2 diabetes, given what we've talked about, insulin resistance for the vast majority of these patients, regardless of what they weigh. Because of that, it is very reasonable, although there's not necessarily a super hard recommendation that you have to do a 1 hour, or sorry, an early 2 hour glucose tolerance test, either preconception or in the first trimester. If that were to be positive, then I would treat them like a gestational or a chronic diabetic patient throughout pregnancy. If it's normal, they still need their third trimester GDM screening. All of this bringing us to a comment about obesity, because we've brought up that a lot of these outcomes are similar or still more common for patients with PCOS, regardless of what their BMI is. And the data will say, and your reference range is as much as 38 to 88%, but about half of patients with PCOS are obese. I don't care which end of the spectrum you're on, that 38 to 88%, the reality is it's not 100. Like, you cannot just say patients gain weight or patients become obese and then they get PCOS. It's not appropriate. And unfortunately, I feel like at least the narrative I heard in med school is that's really all that I heard. There is new research coming out that suggests that there's probably poorly understood genetic factors that actually predispose people to whatever this underlying pathophysiology is, whether it's a predisposition to insulin resistance, predisposition to this GnRH secretion change, whatever it is. The developing theory is that this underlying predisposition to PCOS is basically also a predisposition to likely difficulties with weight gain and weight maintenance. And we know is as patients' weight increases, as their adiposity increases, their insulin resistance increases, their symptom severity increases. So it's more likely that you have patients who gain weight because of some variety of as of yet unknown factors that make it harder for them to maintain a healthy weight. They gain weight, and then that gain in weight potentially unmasks their PCOS symptoms. Or whatever the underlying genetic physiologic changes, we see PCOS symptoms in patients with total normal BMI. So all of this to say is escalating adiposity likely, we know, escalates symptoms. And so being aware of that, but not just saying PCOS is caused by obesity, because that is a gross misrepresentation of what's happening for these patients. Great, you diagnosed them, you checked what their long-term health risks are, you're monitoring for that, but what do you actually do to treat them? And the answer is you treat them based on what's important and what potentially has long-term health outcomes. But ultimately, it comes down to what the patient wants, because they may be overweight, they may not be. They may not care about weight loss, or they may be really adverse to talking about it because they've had a huge emphasis put on their weight throughout their life. They may be trying to get pregnant or not. They may want to regulate their cycles or not have a period at all. And some people really just want to know what those long-term health risks are, but maybe aren't bothered by having irregular cycles. So how aggressive you get with treatment does depend somewhat on what the patient actually wants. When we are talking about menstrual cycle irregularity, as long as their cycles are consistently less than 90 days, then there is not considered to be an increased risk for cancer. And so it's not a requirement or not something that you have to push really hard. If their cycles are greater than 90 days, then it's really important to educate the patient on the risks of endometrial cancer and educate them on what their treatment options are. Combined hormonal contraceptive pills are still considered the first line for cycle regularity management. And the reasons why, which we already touched on a little bit earlier, is estrogen increases sex hormone binding globulin. That binds up free testosterone and reduces metabolically active testosterone. So it's going to reduce the severity of symptoms because you are treating that elevated level of testosterone. Estrogen and progestins combined provide negative feedback on LH to help reduce the pathway that's leading to increased androgen production at the level of the ovary. And also, if patients are dealing with a lot of acne or hirsutism, then it's the decrease in the free testosterone while also improving cycle regularity will also help improve your hormonal acne. If a patient shouldn't or does not want to use any estrogen containing products, then your progestin, your LARCs basically are a reasonable safe option. So your Nexplanons, your IUDs, your hormonal containing IUDs, those provide endometrial protection. So the amenorrhea associated with those is totally safe, just like it would be in other patient populations. And that's good for those patients that really do want birth control. They really do want to stop their periods because the irregularity is bothering them a lot. That's a great option for them. And the amenorrhea in that case is not considered abnormal or dangerous. Treating hirsutism is a little unsatisfying for a lot of patients, and it's important to let them know that unfortunately drug therapy is probably not going to, it won't eliminate their existing hair growth. It might make it less dense, less coarse. They might have to do physical interventions less often, but it's not going to take it away once it's there. The Ferryman-Galway score can give you that objective diagnosis and help you get a baseline. The first line treatment is, again, a combined hormonal contraceptive option because estrogen lowers the metabolically active testosterone levels through sex hormone binding globulin. You really should be giving patients a solid 6 months on their oral contraceptive pills before you would consider it like a failure of hirsutism management or suboptimal management. I kind of think of it the same way I think of acne treatments. Is the vast majority of teens or young adults come in and they want an acne treatment that's going to solve their problems now. And for most of them, you try to tell them, got to hold it out for several months before you're going to know if this is working. And the combined contraceptive pills are quite similar in that regard for management of hair growth. Is if they can go 6 months, great. When you hit that 6-month mark, if results are still not what they would like it to be, then it's reasonable to add in an anti-androgen like spironolactone, starting at 25 to 50 milligrams daily. People will probably and not infrequently get a little bit hypotensive when starting these medications, but if they're otherwise healthy, usually their body will correct for it in a reasonable period of time. So just make sure they're being safe, they're staying well hydrated, they're being mindful about their position changes, that sort of a thing. But for the most part, folks will eventually tolerate these medications. If a patient does not want to or cannot be on a estrogen-containing birth control, and they really want management for their hirsutism, it's reasonable to start them on a anti-androgen monotherapy. However, please, 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 please talk to them about an alternative form of birth control. So we all know that you do not want to get pregnant on an anti-androgen. And also, if you have irregular cycles and you have no idea when you may or may not be ovulating, it's a really dangerous thing not to have a reliable and consistent form of birth control if you're not trying to get pregnant. And so just very much educating them, if they don't want a hormonal birth control for treatment of their hirsutism, that they really should have some other plan in place if they're sexually active with a partner of the opposite genetic makeup. Lifestyle recommendations and weight loss, I think, is something that patients really want to put a lot of stock and energy in, especially if they are overweight. But again, not every PCOS patient is overweight, and not every PCOS patient wants to focus on weight loss. However, if patients are obese and they are interested in pursuing weight loss, even a modest 5 to 10% is associated with improved metabolic status, reduction in androgens. Was doing really good from a coughing standpoint there for a while. If patients are interested in weight loss, that 5 to 10% is associated with improvements in their metabolic profile, improvements in cycle regularity, and so on. There's not any research proven specific diet plan that's more beneficial. However, if we're putting a lot of stock in this hyperinsulinemia or increased insulin resistance theories, then following a diabetic-esque or a Mediterranean type diet is always reasonable. So avoiding those refined carbs, eating small meals, low glycemic index, all very reasonable. You would want to consider weight loss medications like you would for the general population. There's no specific studies on the GLP-1s at this point, but again, because of our talks of the insulin profile, I imagine they will be, they are being studied, and then there's a possibility maybe we'll even get like some FDA approvals to treat PCOS related weight specifically with our GLP-1s. And then we should consider bariatric surgery probably a little bit more often than we do when it's appropriate, but it's just not something that's accessible for a lot of patients, especially if we're providing care in rural areas. So being mindful of that. There are some supplements that have been shown to have some potential benefit. In one way or another, they're all thought to decrease circulating testosterone, improve ovulatory function, decrease insulin resistance, that sort of thing. D-chiroinositol and D-penotol, there was a note. So these all come from this really fabulous dietary health book that one of my attendings has that I have the citation for, but they do comment in there that when they were looking at non-obese IVF patients, that they saw worsening egg quality, and so probably should limit this particular recommendation to obese or insulin-resistant patients. Myoinositol 2 grams a day, again, thought to help with the insulin profile and testosterone. The vitamin D studies that were quoted weren't exactly high quality. There wasn't like a placebo control in them, but depending on where you're practicing medicine, it's probably a good thing for your patients to be on vitamin D regardless, like for where we are in Coeur d'Alene. So take that for what you will. Chromium was another option, and then selenium as well, thought to help reduce or improve those insulin resistance profiles. Interestingly, this one did supposedly see an increase in pregnancy rate as well. A comment on metformin, because I think that's one of the other points that stuck from med school is everybody with PCOS should be on metformin. Anecdotally, I've heard a couple of patients, even some folks that work in my office, who have said, yes, I got on that medication and my cycles regulated right away. Unfortunately, the actual data looking at that has not actually proven that metformin for PCOS patients actually increase. It hasn't proven that it actually increases their cycle regularity. So the newest guidelines suggest that you probably should only be using it if the patients truly have insulin resistance or as part of their appropriate diabetes management plan. I'm always entertained when I think about the mechanism of action for metformin as it pertains to like sugar management in the body. So metformin, of course, inhibits hepatic glucose production. It increases insulin sensitivity in peripheral tissues, decreases intestinal glucose uptake. My favorite one, though, is it disrupts efficient cellular metabolism. So basically makes the mitochondria not work as well to increase cellular glucose uptake. So it's your fun little fact for the day. Metformin is generally considered safe in pregnancy. So if a patient is on it and they are able to conceive, that's totally fine. But you should probably stop it once they conceive unless they're diabetic, and then consulting with their appropriate OB team if you want to continue that as part of their diabetic care. Prescribe it just the way you would for any other patient, starting at 500 milligrams, probably with dinner, with a meal to reduce the GI side effects, and then escalating as tolerated to a max of 2,000 milligrams a day. My kind of last note, particularly regarding fertility. Now, everything that we have talked about up to this point is very reasonable for any of us to do in the primary care office, kind of regardless of where our scope of practice lies, whether you do a lot of women's health or not. fertility might be outside that comfort zone for some people. And I think that's reasonable and appropriate to pass that on to potentially your OB-GYN colleagues if that's not something that you want to dip a toe into. But if you are prepping patients for that, a few things to know. So data for, again, obese patients specifically, not PCOS, but obese patients specifically with PCOS. There are higher live birth rates if you do the preconception counseling, weight loss, and lifestyle modifications compared to if you just immediately put them on a ovulation-inducing medication. So if a patient is obese, and in general, going into pregnancy, having some weight reduction, reducing your overall risk profile is favorable, but specifically, there is evidence that there are higher live birth rates if you can do that for obese patients with PCOS. The two medications, so letrozole and clomiphene, technically clomiphene is the only one that's FDA approved. However, letrozole is becoming the crowd favorite. There's higher live birth rates, and it's thought to probably have a more favorable side effect profile. So letrozole is your aromatase inhibitor. It's going to reduce conversion of other hormones to estrogen in the periphery. So you should get increase in FSH to help increase basically follicle maturation and ovulation. It's felt like there's a lower risk of multifetal gestation, lower teratogenicity risk for kiddos, and then the anti-estrogen side effects are supposedly a little bit more favorable compared to clomiphene. Clomiphene is your selective estrogen receptor blocker, and that's going to reduce your peripheral sensitivities to estrogen, and that's going to lead to increase in FSH and that ovulation. So again, I don't think it's out of the realm of possibilities for some primary care offices to do this if it's within their scope of practice and that is something that they do, but this is definitely probably the point where it's very appropriate to pass patients on to your OB-GYN colleagues, especially if this is not something you do fairly regularly. Some really good resources for providers as you are treating these patients or reminding yourself about caring for them. The Canadian Medical Association Journal has a very lovely and I feel like incredibly digestible article on PCOS diagnosis and management. That's where the big the like hormonal pathway diagram at the beginning of the presentation came from. I feel like for some patients, it would honestly be a reasonable resource to direct them to learn. The American Society for Reproductive Medicine has their recommendations, and it's this big chart, basically, that lays out the different recommendations as far as diagnosis, monitoring, long-term health stuff, and they actually give a rating scale of kind of how data supported these recommendations are, sort of like the USPSTF does. So that I felt was really helpful, and I feel like it really helps walk you through it well. Up-to-date resources are honestly pretty decent for PCOS if you're looking at clinical manifestations of PCOS, diagnosis, and then the treatment options. I found those particular articles fairly helpful. And then, of course, if you are someone who's doing letrozole or clomiphene, they have articles on that as well. And then my general resources, this Gabby is the book that my attending has. It's a very large book on nutritional health that can be helpful for a wide variety of things. So do with that what you will. And then I don't think that's appropriate for you guys. That was from my CME from when I did my grand rounds the last time. So. And that's that.
Thank you, Dr. Lessard. Perfect timing. Really appreciate your presentation. We do have a comment from Dr. Kern in the chat. I don't know if you want to take a look at it. He's doing. Go ahead, please respond.
Let me just find it. Let's see.
He says everyone with
PCOS. Yep. Yeah, so yes, I agree. Everyone on PCOS was classic. And honestly, I would say even up to recently, like in the last couple of years, is when data finally came out that said maybe this isn't appropriate for every patient. Maybe we're not actually getting the outcomes that we thought we were, but I think anecdotally, a lot of providers, especially folks who have been practicing for a while, are still very much of that mindset. I don't know if it's unreasonable to try it, but I would say all of the PCOS patients I've tried it in, they have not tolerated metformin. They've had significant GI side effects despite our best efforts. So I don't know that it's something that you have to stick really hard and true to, especially if a patient's not tolerating it, because the outcomes may not really be worth the effort.
Thank you. Dr. Kern, is there anything else you'd like to say on that? Unmute or anything? Or is that good? Okay. And then anybody else have a question? Feel free to unmute or type it into the chat. Give you a second to do so. And Dr. Kern says only that people often tolerate XR metformin better than GI from GI standpoint.
Right, yes. The long acting, yes, is generally better tolerated. That's the only one I've ever tried and still kind of had mixed results of whether or not people want to be on it. But again, it's a very low risk intervention to try. It's just the data maybe isn't supporting as widespread of a use of it as we have historically done.
All right. Well, thank you so much, Dr. Lessard. Just for everybody here, our next grand rounds will be Monday, June 9th, and it will be with the Full Circle Health Boise program. I'm not privy to a topic yet, but I will be sharing those in our e-news and to emails to past attendees and the programs. So we hope to see you then. If you filled out the Google form, which I'm going to drop in again right now, or email me, you can get CME and you'll be getting a certificate within the next month. And then a recording of this presentation will be on the publications page of the IAFP website. Dr. Lessard, is there anything else?
Nope, that's all. Thank you all for bearing with me as I had my minor interrupting coughing fits, but I think we made it through okay.
Well, you did great, and I hope you feel better soon, because that's a lot to be working and presenting and recovering. So thank you for your time. We appreciate it.
Thank you.
Have a great day.